very high tech.
It's actually an old technology, but it's been applied in new ways.
With the MRI.
The neurosurgeons use this for brain biopsies. The ENTs use this to navigate the sinuses. And now we're using it to navigate the prostate.
And so you get a prostate biopsy back. And we know until there's tissue, there's no issue, like you said.
Correct.
So patients must undergo the biopsy. Biopsy comes back, you get a phone call, come back to the doctor's office, there's prostate cancer. What are the treatment options available here in Brooklyn at the Maimonides Prostate Center?
So I have to tell you, I would never give somebody a diagnosis over the phone.
Of course.
You know, and I'm sure you do the same in your practice.
Come on in, we have a long
there's
talk.
Something we have to talk about. And even a benign diagnosis is not given over the phone because, you know, the patients then go off and say, you know what, I don't have cancer, I'm good. But they don't realize they need to be rescreened periodically if they're of an age where, you know, prostate cancer is still an issue.
We live in an age here where people are moving out of the office trying to do everything over the phone or everything on the iPhone.
Everything on the internet,
Nothing
right?
replaces the face-to-face conversation in the
Really
office.
true.
I tell patients all the time, my MRI, my CAT scan is normal. Still, come on in because the MRI and the CAT scans look at many other areas and there's sometimes findings that we didn't expect. So I always sit there in the office when I have to go over an MRI or a CAT scan with the mannequin or the pictures. The phone can't replace this at all. And I know we're moving into that iPhone era of possible telemedicine, but to me, nothing replaces that face-to-face encounter.
There's no telemedicine for telling somebody that they have a potentially deadly disease.
Exactly.
There just isn't. So the patients come in and we discuss the diagnosis and the grade and the clinical stage and what it means. And if there's any additional testing to be done, we'll order it. Most of the time now, people are coming in with PSAs of less than 10. The risk of distant disease is extraordinarily low because
the risk
PSA
of distant disease meaning that it has
outside
spread,
the
right,
prostate to other parts of the body.
So that's rare with a PSA low.
Very unusual. Now, it's not impossible, but it's unusual. And most of the discussion centers on what to do about the tumor where it started in its primary location. And for that, there are a number of options.
And so where do you go? What are the options available at Maimonides Prostate Center? I know from medical school and from even taking care of patients in our own office that there are multiple ways of going after this disease.
So the goal is not complete tumor eradication the way people think. The goal is to die from something else. And I tell patients this all the time, and first they look very taken aback, and then they understand that it might not be necessary to kill every tumor cell to achieve that goal. So I don't care if there's 10 tumor cells inside, if you can give a treatment that has minimal side effects and stops the growth so that it doesn't spread and they die from something else, that's success.
But you're a surgeon. You want to cut. You want to, right?
So there are some
or is that
tumors,
changing?
No, that's all changing. There are some tumors that can be treated in the manner that I described. There are some tumors that will never be a problem, and the old model of care was you'd find the tumor and you would treat it 100% of the time. And it turns out that's not necessary. For people who have low grade, low volume, non-high risk prostate cancer with a low PSA, it may not be necessary to treat them, ever. So those patients are put into a deferred treatment program. This is not, the watchful waiting as in the Scandinavian studies where people were left with no treatment until they broke a bone from metastasis. This is continued follow-up with PSA periodically, exam periodically, rebiopsy at specified intervals of around 12 to 18 months. And for carefully selected patients, some of them may never require treatment.
So we're not just sending them out the door saying, hey, you don't need anything right now. They're put into a protocol of follow-up with you.
Once you have the diagnosis, you have the diagnosis forever. And irrespective of what the primary treatment has been, you're still, quote, a cancer patient. And there are patients who have trouble dealing with that, and we have plenty of support groups and psychological and other services to help with that. But to get back to what to do, so there's some patients, excuse me, who will never require treatment. And those are typically non-high grade, low volume disease, patients who have perhaps a limited life expectancy, 5, 7, less than 10 years, or even people who have just a small focus of tumor. The old days where a little tumor was like was like pregnancy. You could be a little pregnant, but you were still pregnant. A little tumor does not necessarily mean that you have a life-threatening cancer. A little tumor may mean that this is going to sit there and not be a problem. There are a lot of people who will accept that. There are some people who can't live with that, and they absolutely want treatment. The whole, so to continue with the treatment piece, there are a number of whole gland treatments, and then there's a changing treatment concept of partial gland treatment. I'll talk about both of those. So the whole gland treatments probably all the viewers are familiar with. Surgery to remove the prostate or radiation to stop the growth or to destroy the tumor within the prostate. Surgery obviously is invasive. It's less invasive now than it used to be. When I was a resident, a fellow, you made a cut from the belly button down to the bone, spent 3 hours taking the prostate out. Guys were in the hospital for 3 days, had a catheter for 3 weeks. You know, there's a risk of problems with the urinary control, problems with the sexual function. Today, these are done laparoscopically, usually with robotic assistance. Probably about 90% of prostatectomies in this country are done that way. The hospital stay at Maimonides is less than a day. It's essentially an ambulatory procedure.
So they go in for the operation, 24 hours later, they're
Not 24.
less than 24.
The guy who starts in the morning is home for dinner.
In his own house. That's incredible.
Sitting in his house, sitting at the dinner table.
Things have changed.
Things have changed dramatically. Part of it's due to advances in anesthetic technique, less use of postoperative and intraoperative narcotics. Part of it is that unless you challenge the expectations, it will always be the same. So we have really made an effort to get people out in a realistically quick fashion.
Wow.
And it's reduced a lot of the side effects and a lot of the complications and a lot of the trepidation about having surgery. Nevertheless, it's still surgery. Even if it's minimally invasive, I still have to make an incision big enough to get the prostate out through, and there is still some disability afterwards.
And you mentioned sometimes not taking the entire gland.
So I'm almost at that. So radiation is the other standard whole gland treatment, and it could be any one of several types of radiation, whether it's the external kind or the implant or a combination of both, or the high dose rate or the hypofractionated. They're all just different forms of radiation. It doesn't always kill the tumor, but it may keep it at bay long enough to achieve that goal, which is to die from something else. And radiation is very good. It's been around for a great many years. There have been many refinements in the way it's delivered. We no longer have problems with the bowel. The problems with the sexual function markedly reduced. It's a very good treatment option. But again, it covers the entire gland. So you're treating the whole prostate, and the side effects are very similar to surgery. Problems with the urinary control, problems with the sexual function. The newer treatment concept, which I alluded to earlier, is focal therapy, which is just treating the part of the prostate that's got the cancer in it and leaving the rest of the prostate intact. And when you do that, it doesn't cause as much damage to the sexual function. It doesn't cause as much difficulties with the urinary control. How good is it at treating the cancer? It's a relatively new concept, and we don't really know yet. But it's not something that can't be retreated. And it doesn't preclude somebody having whole gland therapy if that becomes necessary. Now, this concept is very similar to the way breast cancer is treated. You know, years ago, we were taking women's breasts off for breast cancer and leaving them horribly disfigured. And today, breast cancer is treated for the most part with lumpectomy and radiation or medication. And why shouldn't prostate cancer be the same way?
I think we're moving, the entirety of medicine is moving into more focal treatments. You know, we're not blasting everybody with chemotherapy that affects the whole body these days. We're using more targeted therapies, and this sounds like the next, possibly the next step in prostate care.
Well, this is truly minimally invasive because there's no incision, there's no radiation. It's the process that we've been using at Maimonides is high intensity focused ultrasound.
I was just reading this that I have to get to asking you about this. I've never heard of this before. Tell us a bit.
It's not a new technology. It's actually quite an old technology. You do biliary lithotripsy?
Sure we do.
It's exactly the same technology. The people who developed lithotripsy, which is an ultrasound technology, who were able to miniaturize it, package it into a transducer that both delivers the energy and monitors with a diagnostic ultrasound, and protects the venue through which the ultrasound waves go, which is usually the rectum, and really lesion just a specific part of the prostate to destroy the tumor just in that location. Now, years ago, this was applied as a whole gland therapy, and in Europe, they've been doing this as whole gland therapy for over 12 years. And the results are very similar to what you would expect from a whole gland therapy like surgery or radiation. Very good at destroying the tumor, very good at lowering the PSA down to nothing, but it has very similar side effects because you're treating the entire gland. The expectation is that focusing the ultrasound to just the area where the tumor is going to decrease the side effects. There are other modalities. There's cryoablation, which destroys tumors by freezing them to death. There is irreversible electroporation, which destroys them by disrupting cell membranes. There is interstitial laser coagulation, where you put a laser directly into it and essentially barbecue the thing. But these are technologies, some of which are not salvageable. After cryoablation, it's very hard to go ahead and remove the prostate or irradiate it if necessary. After high-intensity focused ultrasound, if it doesn't work, or if there's an area that needs to be retreated, or another area the prostate develops a subsequent cancer, that area can be treated as well. And if whole gland therapy is necessary, you can get the prostate out.
So
you could
always go back and do more if you need.
You could.
For the patient. So there, for the viewers out there who are watching this and might be overwhelmed by all these options that are available, it's important to see an expert like Dr. Silver at a cancer center, a prostate center, where you can have the availability to meet with the different doctors and the specialists to figure out what's the best treatment for the viewer. But still it remains, the patients have to get checked. They have to go to their primary care doctor. They have to get a PSA test when it's appropriate. What age should they start thinking about this?
That is the million-dollar question. So it's clearly
Tell us,
true.
Dr. Silver.
I do not have the answer to that. My professional organization, your professional organization, the AMA, many medical societies have gone through various iterations of what's the youngest age that you should test at. We know what the oldest age is. The oldest age is the point at which the patient would no longer be at risk of dying from a small localized prostate cancer if it was found. And because it takes about 10 or 15 years for a tumor to grow, that point is where the person no longer expects to live 10 years.
Which is difficult in some cases,
It's
but
a tough
there
call
are
sometimes.
calculators out there that we can use to help figure. We have the same problem with colon cancer screening. The guidelines recommend stopping at some point, but we have patients who are 80 years old that run marathons, and who am I to tell them that we should stop checking them?
So my usual response to this is that if a patient comes in and he's 75, and he comes in with his dad, who's 98, and wants to know what I'm going to do for the boy, that guy clearly has probably got a decent
He
life
has some good
expectancy.
DNA, right?
Yeah, the average life expectancy of a white guy in the United States is about 77, 78. But this guy who drives to Montana every year to go fly fishing with his buddies is probably not the same as the,
You're gonna
as
check
the
him.
average.
Yes.
That guy's
Yeah.
getting checked. So the
So-
opposite end of the question is how young do you
Right.
need to go? Nobody really knows the answer to that. I have had patients
That's
who
tough.
were screened, I don't know why, but who were screened in their 30s and had prostate cancer.
1 minute.
And at that point, there's nobody who's not going to biopsy and treat a 30-something-year-old man. But there's no recommendation to screen that early. Nevertheless, there are people who have a family history, African-American, Caribbean, they've seen their friends and their relatives get prostate cancer, and the concept is not screening. In that case, the concept is early detection. And it's never wrong to do an early detection
That's
biopsy.
exactly what I'm going to get at to conclude here for our viewers who might be saying, hey, when should I get checked? Individualized, may never be too early. Speak with your primary care doctor, which is
Absolutely.
the most important thing. And I really thank you for coming on the show. This is incredibly educational. For me, as a physician, I learned a lot, and I'm sure our viewers have a lot to digest here. But they can find you over at the Maimonides Prostate Center. And thank you, Dr. Silver. It is really a pleasure to have you on this show.
Thanks so much for having me.
Thank you for your interest in our show. Desire to become more involved and educated in your health and our community, please visit our website at www.medcastplus.com and engage with us on social media. You can also reach out to us by phone at 718-510-2103. Stay well, stay healthy, Brooklyn. Have a great day.